Thank you very much. Good day to everyone. The topic of this lecture today is radiologic evaluation of round pulmonary lesion in children. This study was performed in period of 4 years at the Institute of Radiology-Skopje, University Clinic of Pulmonology, Institute of Lung Diseases in Children, Institute of University Clinic of Pediatric Disease. What is round lesions? The symptom round lesions include pulmonary pathological lesions, which in radiological examination in one projection are giving one or more shadows with a round or oval shape in a diameter greater than 1 centimeter. On this slide, we can see conventional radiographs, which means it's conventional radiogram is a basic pillar and the first step in radiological diagnosis of pulmonary diseases. We can see round lesion here, transparent, well-defined on the left side, paracardia basal. On the second image, it's esophagography or contrast method of examination of the esophagus. It's indicated in the evaluation of posterior and middle mediastinal masses, allows visualization of communication. We can also see round lesion here on posterior upper side with no compression on esophagus. Ultrasound. Physical loss for distribution of ultrasound and some anatomical characteristics of the chest limit the routine examination of the thorax, represented in the diagnosis of encapsulated pleural effusions, solid and cystic tumors of the lung with peripheral localization, tumors and cysts in the anterior mediastinum, high diaphragmatic level. Without radiation, easy application, and low price, ultrasound allows to be used as screening method for differentiation of solid from cystic pathological processes bordering the chest wall. For ultrasound, we use 3 megahertz tubes up to 7 with acoustic approach like intercostal, parasternal, transhepatic, etc. On this slide, we can see the thymus. We can see round echinococcal cyst with thick wall and liquid substrate in the middle. On the second slide, we can see the thymus, which is presented on ultrasound. It has structure as a liver, but without compressions on the vessels. These are the vessels. This is a normal hyperplastic thymus. On computed tomography, which was invented 50 years ago, and for that Mr. Godfrey got Nobel Prize in 1979, with CT we get high level of contrast resolution and enormous capability in detection of minor density differences also between the soft tissue structures, especially after we administrate contrast. On this picture, we can see round lesion on anterior aspect of the lung. Magnetic resonance imaging, one of the top medical innovation of 20th century. The advantages are multiplier display and highly contrast distinction without use of intravenous contrast. Indications are evaluation of mediastinal masses, information for craniocaudal extension of the lesion, mass effect on the tracheobronchial tree, visualization of lesions in the apex, basis, and chest wall. Do not stand out particularly in the evaluation of pulmonary parenchyma, but as I said, the main advantages in evaluation of lung diseases includes differentiation between vessels, mediastinal fat tissues, and soft tissues, which was also important for the whole mediastinum. This is MRI in lymphoma. Round pulmonary lesions. On this slide, we can see how we divide in 4 groups these round pulmonary lesions. Most common diseases presented as round pulmonary lesion in children. First group is inflammatory changes as acute pneumonia, abscesses, tuberculosis. The second is parasitic and fungal agents, Echinococcus, Aspergilloma, and Candida. The third is pulmonary tumors, hamartoma, hemangioma, congenital cyst, other malformations, metastasis, pulmonary blastoma, and other causes like trauma, round atelectasis, diaphragmatic eventration, localized effusion. Acute pneumonia, round pneumonia or acute pneumonia in children may produce round lesion on chest X-ray as well defined on initial chest ray. And the most common is Streptococcus pneumonia. They're not rare, and their radiographic recognition may eliminate unnecessary investigation. Abscess. Radiographic image of abscess begins with pneumonic infiltration as a first step. After penetration of necrotic mass in the bronchus, cavitation becomes visible, and we can see hydroaeric level. After complete expectoration, necrotic masses remains residual cavum with thin walls. Differential diagnosis may be bronchogenesis, complicated cyst, tuberculosis cavernosum. Pneumatoxella is formed often after gram-negative bacteria as Escherichia coli, and it can be visible up to 6 months. And tuberculosis, this is a primary tuberculosis, and our country is also endemic region, even the vaccination is high, maybe 90% and much more. Primary lung tuberculosis in children may not have pathognomonic radiographic presentation, so we'll need additional laboratory microbiology and epidemiologic or social economic factor of the child. Initial pulmonary focus may present a round lesion with different dimension, and its hilar glands are enlarged. It can also help with differential diagnosis. Cavitation in primary focus and in children are rare. It is very different, the picture of tuberculosis in children and in adults. Parasitic disease. Echinococcus granulosus, or on the first picture here, you can see the hidden cyst. It's relatively commonly diseased in children, and also our country is an endemic region for Echinococcus granulosus for this parasitic disease. Radiographic presentation shows many phases, like simple uncomplicated cyst, which is round or spheric lesion with sharp margins and different dimensions, up to an orange. Because of infective and mechanic reasons, it can be complicated. Penetration of air between the cuticula of the cyst and adventitia will present half moon or air crescent sign or peripneumocyst sign. If the cyst perforate, it can appear hydroaeric level, which is not flat but wavy, like in this picture, due to germinative membrane of daughter cyst, which is called the sign of Camalote, and it's very pathognomonic for these types of complicated parasitic disease or complicated Echinococcus granulosus. Like this is simple and complicated cyst. Primary tumors, these are peripheral localized lung cysts, hamartomas, hemangioma, metastasis, and pulmonary blastoma. True pulmonary tumors in children are very, very rare, and if we find them, they can be, as I said, peripheral localized lung cysts, hamartoma, the most common benign tumors, 1 to 3 centimeter, made of mixed or normal components of different organs, tissues, plus calcium. Hemangioma and metastasis are probably more often than any other primary malignancy in children, from which most familiar is pulmonary blastoma. CT has biggest sensitivity, but definitive diagnosis is made with pathology. These are metastases in children. Other causes like trauma, spontaneous bleeding, and in coagulopathies, round atelectasis, diaphragmatic eventration, interlobar effusion can cause round lesions. Blunt trauma, this or unexpected compression of the chest, often without ribs fracture, may produce a round pulmonary lesion due to intraalveolar or intraparenchymal bleeding or penetration of air. They should not be mixed with pneumatoceles or abscess. There is not hydroaeric level. You can see that this is not hydroaeric level, but rather vertical line, which is also in a very good connection with the vessels. In coagulopathies, there is no data for trauma. So this was a trauma of child after a car crash. This is also trauma. You can see this sound that the hydroaeric level is not horizontal, but vertical. Mediastinal masses, 1/3 are accidentally revealed, 1/3 occur in less than 15 years. And there's most mediastinal masses in children are presented as round pulmonary lesion. And they are also very big diagnostic challenges because most of, 1/3 are accidentally revealed in the beginning, but most of them are serious malignant conditions. For more practical analysis and differential diagnosis of mediastinal masses in children, Dr. Kirks modified the classical anatomic division of the mediastinum in this category, like anterior mediastinum, middle and posterior. Anterior mediastinum, like 4T, thymus, steroid, teratome, and terrible. And middle mediastinum, like 2AB, adenopathy and bronchopulmonary malformations, and posterior mediastinum 1N, this mistake, neural tumors or neural abnormalities. Anterior mediastinum, 30% of round lesions are found in anterior mediastinum. Most frequently are thymus, normal prominent, hyperplastic, thymoma, thymic cyst, steroid, teratoma terrible, lymphoma, and leukemia. This is normal thymus. Why it's a normal? Because this shadow we cannot see in the lateral radiogram. If it's a mass, we will see it also here or maybe here. So this is a very pathognomonic and very often unexperienced or young radiologists can mix it with masses and continue with CT or MRI, and which is of course unnecessary for the children. That's why it's a very also big challenge for diagnosis. Middle mediastinum 2AB or 30% adenopathy. It can be inflammatory, bacterial, granulomatosis, leukemia, lymphoma, metastatic disease, as I said, and bronchopulmonary malformation, bronchogenic cyst, sequestration, enteric cyst, diverticuloma, and neuroenteric cyst. Mediastinal cyst, long time can be asymptomatic. Radiographic differentiation between bronchogenic and enterogenic cyst is difficult because very rare they are connected with respiratory or digestive tract, and the diagnosis is made by pathology. MRI not only confirms the localization of the mass, but also its content. This was the case of esophageal diverticuloma, which was first thought as a mass, but after and performed MRI, we can see that the component is made of liquid. So this is a case of esophageal diverticuloma, confirmed surgical and pathological. As I already said, it's a mass on the right side paravertebral, but it's connected with thin line with esophagus on the left. Posterior mediastinum, neurogenic tumors in posterior mediastinum are most frequent masses in the posterior mediastinum in children under 4 years. Predominant type of tumors are malignant neuroblastoma and ganglioneuroblastoma. Second one is more differentiated and with better outcome. In older children, benign ganglioneuroma is most frequently histological type. Tumors are often asymptomatic, but they produced back pain and symptoms due to compression of the spinal cord. Neuroblastoma. Here you can see the ribs erosion, and that's why we made further investigation, because we already saw that there is rib erosion. So it must be, unfortunately, malignant. So where we should look for this one, for analyzing the radiograms and not to make possible mistakes. Neurogenic tumors usually appear as round or oval soft tissue masses with relatively sharp contours on one side of upper mediastinum. Frequently, we can see shift of the trachea, esophagus, erosion of the ribs, as I said, and widening of the intercostal space. Tumor growth into spinal canal gave destruction of peduncles and vertebrae. Diagnosis is confirmed with CT, which can show us showing solid masses with soft tissue attenuation, which may have calcification and involves ribs and vertebrae. MRI can demonstrate multiplanar section of the spinal cord and eventually intraspinal extension of the tumor, which is very important for surgical intervention and therapy plan. Results of this study: 149 patients aged 0 to 18 were analyzed. All pathologies divided into 3 distinct groups, statistically processed, 131 in number. The first group, inflammatory disease, the second, parasitic, the third, tumors of the mediastinum. The overall statistical analysis of each includes variables like sex, age, location, and size of the shadow. It is noticed that prevalence of respiratory disease is seen in male population. First explanation for this phenomenon gives Martinez due to different bronchus diameter in favor of males. This is called risk factor in male population. Look and see the distribution, inflammation, parasitic, and tumors are male. This is also age distribution, and inflammation has peaked between 1 and 3 years, and after that is reducing. In parasitic diseases, most frequent distribution is between 6 and 15 years. One explanation for this is slow growth of the hydatid cyst and later presentation of the symptoms. And age distribution in tumors are predominant in age between 3 months to 3.5 years. This is because in these groups are included an hyperplastic thymus, which is in fact presented as pseudotumors and not real tumors. That's why that we have a big here difference. Analyzing the size of inflammatory lesions, we can see predominance of 3 to 6 centimeters in diameter. In echinococcus cyst, predominant diameter is 3 to 5 centimeters, and in middle mediastinum tumor have biggest dimensions up to 13 centimeters. In anterior and posterior mediastinum, dimensions are equal. Analyzing the localization of inflammatory lesions, we can see that most frequent they are in the right lower lobe and left lower lobe due to anatomic characteristics of the tracheobronchial tree, easier entering of the pathogen to these regions. Localization of parasitic cysts in the lung are also in the lower lobes, but this time it is explained with regional blood pressure, which is a ratio between alveolar, arterial pulmonary, and venous pulmonary pressure. Radiological. What can we conclude from this presentation? The conventional radiogram or radiograph is the first destination, first step, and basic method in the evaluation of pulmonary round lesions. Modern imaging methods have greater sensitivity for the evaluation of radiological characteristics of the lesion, which show the fundamental nature of the disease. Most patients with pulmonary round lesions are due to parasite etiology, followed by inflammatory diseases and tumors in the mediastinum. For adequate radiological diagnosis, the round lesions in the lungs and mediastinum, necessary is a complex multidisciplinary approach and analysis of clinical and laboratory parameters for timely implementation of therapeutic and surgical procedures. Thank you very much for your attention.